Hi there, my highly valued, treasured, and esteemed viewers and listeners. Welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very, very crucial and non-negotiable to us. Here, we seek to remain your premier source of very crucial tips for very high impact pharmacotherapy services. So I humbly urge you all to sit back and spare me part of your very precious time to share with you some very precious tips which may prove very, very handy in your line of duty. So I welcome you all to part 133 of our Pharmacotherapy MCQ series, Majoring in Infectious Diseases. And the first question reads, Miss PRL, a 6-year-old girl, is rushed to your pediatric accident and emergency department by her mother with a chief complaint of otalgia, ear tagging, and a fever of 38.5 degrees centigrade, which has lasted the past 48 hours. The pediatrician on duty evaluates this patient and diagnoses unilateral acute otitis media with possible effusion and opaque tympanic membrane. So my question to you is, which of the regimens listed below would be the most appropriate for patient PRL now? Is it true that no antibiotic therapy should be initiated at this time? Or would you settle for augmentin co-amoxiclav at a dose of 45 milligrams per kilo per dose orally twice daily for 5 days? Or would you settle for ciprofloxacin at a dose of 10 milligrams per kilo per dose orally twice daily for 7 days? Or would you settle for amoxicillin at a dose of 45 milligrams per kilo per dose orally twice daily for 1 week? I'll give you 10 seconds to choose the correct answer. So A is the most appropriate choice at the moment. It offers the most appropriate therapy to initiate in this particular patient based on her age, which is above 2 years, but not above 7. And we know that there is a presence of fever there, but the fever does not exceed the 39 degrees centigrade. And there is a presence of unilateral acute otitis media without bulging of the tympanic membrane. Now, the key characteristics indicating need of treatment with antimicrobials would be age less than 5 years with the presence of bilateral disease and a fever equal to or above 39 degrees centigrade and or severe appearance. Now, additionally, fluoroquinolones are not indicated for acute otitis media as first-line or alternative therapy. And finally, co-amoxiclav, though utilized as first-line therapy in the clinical setting, is not a guideline-endorsed first-line agent for initial episode of acute otitis media. Then I would like to add that it could be considered if she had presented with recurrence of infection, for example. However, such is not the case as the question is currently written. So I would not go for B, C, or D. I would not administer any antibiotics for now. Let's move to the next question, please. And the next question reads, a division of pediatrics at your university hospital seeks to integrate an outpatient antimicrobial stewardship intervention in the outpatient clinics. They seek to improve appropriateness of use for patients presenting with signs and symptoms of an acute bacterial rhinosinusitis. So my question to you is, which of the following would be the most appropriate method of management of ARBS in this patient population? Would it be A, utilize azithromycin plus a third generation cephalosporin for treatment of ARBS in penicillin allergic patients? Or would it be B, reduce third generation cephalosporin use by initiating amoxicillin monotherapy for patients with acute bacterial rhinosinusitis? Or would it be C, recommend clindamycin plus a third generation cephalosporin therapy for patients with ARBS and confirmed hypersensitivity to penicillins to reduce fluoroquinolone use? Or would it be D, reduce use of fluoroquinolones by listing doxycycline as the first-line agent for patients with confirmed acute bacterial rhinosinusitis? I'll give you 10 seconds to choose the correct answer. So I would recommend clindamycin plus a third generation cephalosporin therapy for patients with acute bacterial rhinosinusitis and confirmed hypersensitivity to penicillin to reduce fluoroquinolone use. I would just like to emphasize that the key finding in this question is that the patient population is pediatric. And in contrast to adult patients, the guidelines endorse utilizing combination therapy with clindamycin plus third-generation cephalosporins when treating ABRS in this cohort of patients. Additionally, although fluoroquinolone reduction is an ideal goal for antimicrobial stewardship intervention in the outpatient setting, doxycycline is not indicated for use in patients below the age of 7 years, secondary to concerns for tooth decoloration and bone demineralization based on older studies and clinical experience with its parent compound, which is tetracycline. Answers B and A are inaccurate because even for pediatric patients, amoxicillin monotherapy is not indicated for acute bacterial rhinosinusitis, secondary to concerns for beta-lactamase producing strains of Haemophilus influenza, and macrolides are not indicated for this upper respiratory tract infection. So that explains why C would be the best answer in this particular question. Let's move to the next slide, please. And it reads, Mrs. LMN, a 37-year-old female patient, presents to your accident and emergency department with a past medical history of heart transplant half a year ago. She also suffers from seasonal allergic rhinitis and she suffers from recurrent UTIs. Today she has a chief complaint of purulent nasal discharge, headaches for the past 10 days, which were initially relieved by over-the-counter remedies until 3 days ago when her condition worsened. She has experienced what we call double sickening. So my question to you is, which of the following would be the most appropriate course of action in LMN's management? Would it be A, instruct LMN to start intranasal corticosteroids to aid in management of her seasonal allergic rhinitis in addition to her ABRS, or would you initiate therapy with levofloxacin 750 milligrams orally once a day for a week? Or would you initiate therapy with coamoxiclav augmentin at a dose of 875 milligrams orally twice daily for 7 days? Or would you obtain imaging to determine if LMN has acute bacterial rhinosinusitis? I'll give you 10 seconds to choose the correct answer. So D would be the best option here. Obtain imaging to determine if she has acute bacterial rhinosinusitis. D is the most appropriate. Now, although this patient meets criteria for acute bacterial rhinosinusitis by virtue of duration of illness and the presence of nasal discharge that is purulent in nature, she is an immune-compromised host for which imaging would be indicated. Additionally, if ABRS is confirmed in the absence of another etiology of her presentation, in my opinion, she would require high-dose amoxicillin clavulanate as the mode of her therapy, which would render C inappropriate. Then I would like to add that fluoroquinolone-based therapy is not indicated in guidelines for this indication. That makes answer B incorrect. Then I would like to add that although intranasal corticosteroids are indicated for both seasonal allergies and as an adjunctive or alternative treatment for patients with ABRS, it would be inappropriate to intervene in this manner only for a high-risk patient. Let's move to the next question, please. And it reads, Mr. TMI, a 58-year-old male patient, presents to the clinic for his annual physical exam. He has a past medical history of type 1 diabetes mellitus. He has chronic obstructive pulmonary disease and has been admitted several times due to acute exacerbation of the COPD. So my question to you is, which of the vaccines listed below should be offered to Mr. TMI during this visit to reduce the episodes of acute exacerbation of COPD, which we abbreviate as AE-COPD? Would it be the PCV7? Would it be the PPSV23? Would it be the PCV13? Or would it be the annual influenza vaccine? I'll give you 10 seconds to choose the correct answer. So PCV13 would be the best choice. Now, immunization with pneumococcal conjugate vaccine has been shown to have a protective benefit in reducing AE-COPD in patients with multiple exacerbations. Now, this answer selection is most appropriate because while influenza vaccine is important as well, clinicians are specifically focused on reducing exacerbations requiring hospitalization, for which the data are stronger for the role of PCV vaccination to achieve that particular endpoint. Additionally, PPSV23 would not be indicated at this time despite this high-risk condition because the patient is not yet 65 years of age. Remember, we are told he is a 58-year-old. So I would just like to add that PCV7 would no longer be recommended over PCV13. PCV13 is superior. Let's move to the next question, please. And it reads, which of the pathogens listed below is most often implicated in acute bacterial rhinosinusitis in adult patients? Is it Pseudomonas aeruginosa, Streptococcus pneumoniae, Haemophilus influenza, or is it Staphylococcus aureus? I'll give you 10 seconds to choose the correct answer. So B is the correct answer here. Streptococcus pneumoniae it is. Now, acute bacterial rhinosinusitis is characterized by a varied set of pathogens as compared to other upper respiratory tract infections. However, the predominant pathogen remains Streptococcus pneumoniae. The other listed agents can be implicated at lower incidences as well. Therefore, the key is identification of which is most likely to be the pathogen etiology. Let's move to the next question, please. And it reads, Miss VWL, a 4-year-old girl, is rushed to your pediatric accident and emergency department by her parents. She has a past medical history of hydrocephalus. There is a VP shunt that was placed in 2015, and she has been hospitalized for respiratory syncytial virus RSV in 2018. There is also a history of mild persistent asthma, which was diagnosed 6 months ago. The chief complaint today is a right ear tagging. There is otorrhea, there is rhinorrhea, there is scratchy throat, dry cough. And this kid has been difficult to console for the last 2 days. She feels warm to touch. And concerning the social history, the mother smokes 3 packets per day, and the father works at a petroleum refinery, and the 2 younger siblings, aged 18 months and 6 months, live with her in the same environment, and they attend nursery school at a local school. So this kid inhales salbutamol at a dose of 2 puffs pro renata up to 4 times daily for wheezing and shortness of breath. She receives ranitidine at a dose of 5 milligrams per kilo per dose twice daily. And she also inhales a puff of fluticasone propionate twice daily. Concerning her immunization history, she received 3 doses of the hepatitis B vaccine in 2015, 2 doses of rotavirus vaccine in 2015, DTaP, 4 doses of that in 2016, and 1 dose of the Hib in 2017, 2 doses of the PCV13 in 2017, and then the MMR, a dose in 2017, then a dose of the varicella vaccine in 2017, alongside a dose of Hep A vaccine, 2 doses of that in 2017. And the pertinent vital signs include a temperature of 40 degrees centigrade, a respiratory rate, the blood pressure, and the heart rate are normal for age. And some of the pertinent labs that reported a throat swab that is negative for strep pyogenes. And some of the pertinent positives include bilateral bulging of the tympanic membrane and otorrhea. So my question to you is, which of the therapeutic options listed below would be the most appropriate for the management of baby VWL's acute otitis media? Would you choose to initiate coamoxiclav at a dose of 90 milligrams per kilo per day in 2 divided doses, that is twice daily for a week, or would you initiate ceftriaxone at a dose of 50 milligrams per kilo per dose, IM once daily for 3 days, or would you initiate amoxicillin at a dose of 45 milligrams per kilo per day, twice daily for 5 days, or would you choose to go for watchful waiting with follow-up in 72 hours? I'll give you 10 seconds to choose the correct answer. I would opt to initiate coamoxiclav at a dose of 90 milligrams of the amoxicillin component per kilo per day in 2 divided doses for a week. Now, treatment with antibiotics is recommended in this patient based on her age, the presenting signs. Remember, the fever is above 39 degrees centigrade, and even the bilateral bulging of the tympanic membranes, and there are even symptoms. Now, amoxicillin 45 milligrams per kilo per day is not the optimal dose for treatment of otitis media based on this patient's age, which is 5 years. The recommended duration of treatment would be a minimum of 7 days, as a patient that is in the range of 2 to 5 years of age. They demonstrate improved outcomes in resolution when it is used for that duration, and a shorter course of therapy can only be considered if the patient is at least 6 years of age or older. And I would like to add that IM ceftriaxone is not recommended for initial therapy of patients who are able to take oral medication, and it should only be reserved for patients who fail to respond after the first 48 to 72 hours of coamoxiclav therapy, and that makes answer B incorrect as well. Let's move to the next question, please. And it reads, which of the agents listed below would be associated with reductions in the incidence of acute otitis media infections and complications in baby VWL's case? Would it be probiotics? Would it be the PCV13? Would it be antibiotic prophylaxis in high-risk patients younger than 23 months? Or would it be the Hib vaccine? I'll give you 10 seconds to choose the correct answer. So PCV13 vaccine it would be. Now I would like to remind you that this vaccine has demonstrated a decline in the incidence of invasive disease in patients, including a reduction of up to 34% in acute otitis media for patients who have received the same. So that would be the best answer there. Now, the use of antibiotic prophylaxis or probiotic administration has not been shown to reduce the incidence of acute otitis media infections and even its complications. So that makes answers A and C wrong. Then I would like to add that the Hib vaccination does aid in reduction of invasive infections secondary to Haemophilus influenza and may impact resistant patterns. However, it does not decrease acute otitis media infections. That makes it the wrong answer. So that slide shows the immunization history of this particular kid, VWL. So my question to you is, considering the vaccination history above, which of the vaccines listed below would be administered to baby VWL to decrease risk for recurrent acute otitis media. Would it be A, live attenuated influenza vaccine, or would it be the PCV7, or would it be the PPSP23, or would it be inactivated influenza vaccine? I'll give you 10 seconds to choose the correct answer. So inactivated influenza vaccine would be the best choice here. Remember, vaccination with the inactivated influenza vaccine has demonstrated a 30 to 50% reduction in recurrent acute otitis media. Now, although vaccination with the live attenuated influenza vaccine has been reinstituted this year by the ACIP as part of the influenza recommendations, this patient is not a candidate for that vaccine because her past medical history tells us about asthma. So there you have it, my highly esteemed viewers and listeners. That brings us to the end of this video. If this video benefited you in any way, I would like to humbly urge you to give it a thumbs up, to like it, and to share it widely with your peers. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the very best is yet to come. And I thank you all very much for viewing this video and for listening to me. I sincerely appreciate your partnership, your continued support, and your very kind collaboration. And I look forward to interacting with you in the next video. Thank you very much.